Welcome back. If you are an endoscopy tech, maybe a nurse or even a trainee just getting started in the GI lab, you definitely know that technical skill is just, well, it's everything. Today we're doing a deep dive into, really, the foundation of handling instruments. We're pulling some essential practical wisdom straight from Dr. G.S. Raju's YouTube series.
That's right, yeah. Specifically, his HGC 1472 Lesson 9A, Tissue Biopsy and Handling.
Right. And the mission today.
It's all about the device you probably touch the most, the simple biopsy forceps. Dr. Raju really stresses this point. If you can truly master the handling of this one tool, from the first grip to how you communicate at the end.
Then everything else gets easier.
Exactly. The learning curve for all the other complex stuff like snares or clips, it just shrinks dramatically. It's kind of the ultimate technical proving ground.
I like that framing,
Yeah.
foundational skill. Okay, so before we even touch the device, let's talk preparation. Because the source material kicks off with this really immediate practical tip, something that prevents, well, chaos mid-procedure.
Oh yeah, pre-labeling. It sounds so basic, doesn't it?
It does.
But it's critical. Before the patient's even in the room, really, before anything starts, you have to label all your formalin jars. It's just smart workflow.
Yeah, I can see that.
Think about it. You're mid-case, things are maybe a bit tense, and you're fumbling for a marker, trying to label a wet jar, matching it to the right site, all while the endoscopist is waiting.
Yeah, not ideal. That little bit of struggle can just break the whole rhythm, right?
Totally. So labeling beforehand turns prep into like a proactive step for safety and efficiency, not just ticking a box.
Okay, so jars are labeled, we're ready, we go grab the forceps. What kinds are we generally looking at, and why does it matter which one we pick?
Well, the choice usually boils down to a few things. The size of the head, whether it has a spike or not, and crucially, if it's for a cold or a hot biopsy.
Okay.
You've got your standard size, which fits pretty much all scopes. These can come with or without that little spike in the middle, the one that helps grab the tissue.
Right, gives it a bit more purchase. And what if you need a bigger sample?
Then you might go for the Jimbo biopsy forceps. It's just a bigger version, essentially. Also comes spiked or unspiked.
Oh, okay.
But the really key difference, functionally speaking, the one you have to know, is cold versus hot forceps.
So, thinking about trainees focusing on foundational skills, why even spend time on hot biopsy forceps right now? Shouldn't they just focus on cold biopsies first? I mean, those are the routine ones for diagnosis.
That's a totally fair point. But you need to be aware of the potential risk, even if you're not using them yet. Cold forceps are simple mechanics that just shear the tissue, no electricity involved.
Right.
Hot biopsy forceps, though, they're different. They hook up to an electrical unit. They use heat, coagulation basically, to cut and seal the area. You mainly see them used for small polypectomies.
Okay, so the risk profile is different.
Completely. Handling the hot type means you need to think about grounding pads, electrical safety checks, things that just aren't relevant for the cold ones. But yeah, for most of your standard diagnostic work, you'll be reaching for cold forceps.
Good distinction. Understanding the stakes for each type is definitely important. Okay, so we've picked our cold forceps, we take it out of the package, unwind that long cord. Dr. Raju emphasizes a very specific way to hold it initially. It's all about managing that cord, isn't it?
Absolutely. How you handle the cord right at the start really sets the stage for the whole insertion process. Your right hand takes the handle, but your left hand, it needs to immediately gather up that long cord and hold the head, creating one single smooth U shape without loops.
Okay, why no loops? Why is avoiding those little kinks or twists so important right from the get-go?
Because every loop, every twist adds friction later on. If that cord is tangled right at the start, imagine trying to push it 150 centimeters down a narrow channel.
Yeah, it's gonna snag.
Exactly. It creates drag, snags. It makes delicate movements impossible for the endoscopist. That clean U shape just lets the cord pay out smoothly. No resistance.
Makes sense. Okay, let's talk about the grip itself. The right hand on the handle. That thumb ring looks simple, but mastering it seems key.
It really is. That thumb ring is your control center, thumb slides right in, and then your index and middle fingers grip the main handle part.
Right.
The action itself is direct. Close your grip, the jaws close. Open your grip, the jaws open. You need that muscle memory, that separation between moving the device, which the endoscopist does, and opening, closing the jaws, which you do.
And that separation leads right into this sort of cardinal rule for the pre-handoff check.
Yes. Critical step. After you've quickly checked it opens and closes, okay, you must absolutely, no exceptions, make sure those jaws are fully closed before you hand it off.
Why closed?
It protects the patient, obviously, but also, very importantly, it protects the inside of the endoscope, the channel itself.
Ah, okay. So keeping it closed sets up that next critical moment, the handoff, moving from your control to the endoscopist's.
Exactly. And that handoff needs to be smooth, almost invisible. The endoscopist usually takes this specific stance, kind of a pinched grip, with their thumb and index finger out.
Right. I've seen that.
Your job is to slide that forceps cable right in between their thumb and forefinger. They should be able to grab it instantly without looking away from the screen, without breaking their focus or moving the scope. Precision avoids fumbling, keeps the procedure flowing.
Okay, handoff complete. Endoscopist starts inserting. Now the assistant's left hand comes back into play, right? For managing the cord during insertion.
Yeah, and it's not a passive role at all. As the cord feeds into the biopsy channel, your left hand needs to actively manage the slack. You create this nice upward loop.
An upward loop. Why upward?
It fights gravity and friction. It stops the cord from dragging on the drapes or the floor. Any drag creates resistance, and that makes the endoscopist struggle to push the device smoothly all the way down the scope.
So active management prevents struggle. But let's talk about something more serious damaging the scope itself. You mentioned protecting the channel. What happens if the assistant accidentally opens the grip while the forceps is moving inside that channel?
Oh, that's a huge mistake. Costly mistake.
Yeah.
The absolute most important rule for protecting that channel. Your right hand grip stays closed. Forceps jaws stay closed whenever that device is moving, in or out.
Okay.
If you open that grip even a tiny bit while it's moving, those sharp jaw edges are exposed. They act like little razors against the delicate lining of the channel.
Ouch.
You can literally tear the channel lining. That scope is immediately out of commission. We're talking thousands in repairs, delaying other patients. It's bad news. So grip closed, forceps closed, scope protected.
Yeah.
Always.
That really clarifies the why. You're protecting a, $30,000 scope from a $10 device? Okay, so scope's protected, forceps is at the target lesion, now the mechanics pause and the communication starts.
It really is like a little dance, a choreographed dialogue. The endoscopist handles the placement, the pushing, but the assistant controls the actual bite. The commands are simple and clear.
Right.
Endoscopist says open. You snap the grip open instantly. They push the open jaws onto the lesion. Endoscopist says close. You close the grip firmly to grab the tissue. Then they gently pull back to get the sample. Your timing has to be immediate, reflexive.
Reflexive timing, got it. And then comes retrieval. This introduces another small risk spills, contamination. As the endoscopist pulls the forceps back out, what's the assistant doing?
Good point. As they start withdrawing, you need to help manage the cord again, creating those nice clean loops. But also, crucially, have a piece of gauze ready right at the biopsy port valve.
Okay, why the gauze there?
It's not just for wiping. It's there to catch any fluid, maybe some bile that might drip or splash out of the biopsy cap as the wet instrument comes out. Keeps the field clean, prevents messes.
Smart. Okay, specimen is out, sitting there in the jaws. Before it goes in the jar, there's an assessment step.
Yes, just a quick visual check. Look at it. You have a good specimen.
Yeah.
Now, does it look like actual tissue? Is it intact?
Makes sense.
Once you're satisfied, you carefully drop it into that pre-labeled formalin jar. And be careful just to tip into, don't drop the whole forceps head into the formalin if you can help it.
Right. And this is where communication becomes, as the source says, absolutely non-negotiable. Loud, clear communication. What are the two mandatory things you have to say and why so loud?
Yeah, this isn't optional. It's a safety and documentation checkpoint.
Yeah.
It needs to be loud enough for the endoscopist who's still focused on the screen and the nurse who's charting everything to hear clearly, no mumbling.
Okay, what's statement one?
Statement one is location. You say exactly which jar it went into, specimen in jar A or jar B, whatever it is.
Clear. Ensures the path lab knows where it came from.
Wow.
And the second statement, that's feedback for the endoscopist.
Exactly. Statement two is quality assessment. You state the size or apparent quality, good specimen. Or, importantly, specimen is small. Or fragmented.
Ah, okay. That tells them if they need another bite.
Precisely. This is the immediate feedback loop. If you skip this or just mumble it and the sample was actually tiny or inadequate, the endoscopist might think they're done. They might pull the scope out only to find out later the sample wasn't good enough. Clear communication here saves time, avoids reintubation, and ensures you get the diagnosis.
Critical loop. Okay, specimens in the jar, communication's done. If more biopsies are needed, how do we prep the forceps for the next pass? It's not just wiping it off.
No, it's a bit more specific. After dipping the tip in formalin to release the tissue, you've got formalin residue on the jaws. You need to clean that off.
How?
Dip the forceps Tip immediately into a separate basin of clean water. Swish it around. Then dry it, maybe with gauze, before you hand it back or prep for the next insertion.
Why clean off the formalin?
2 reasons. 1, formalin can be corrosive over time, potentially damaging the instrument mechanism. 2, any residue can cause friction or stickiness on the next deployment. You want a clean, smooth device every single time. Water rinse, then dry.
Got it. Okay, finally, before we pull all this together, the source material mentions a brief safety note about biopsies in general.
Yeah, just a reminder that overall, endoscopic biopsies are very safe procedures. The main thing to be aware of, the primary risk noted, is increased bleeding.
In specific patients?
Right, particularly in patients with known blood disorders or those on anticoagulants or antiplatelets, people whose blood is, very thin. That patient-specific risk is the main safety flag to keep in mind throughout the case.
Okay, so let's synthesize this. What does this incredibly detailed focus on the biopsy forceps really mean for someone learning or working in endoscopy? We said mastering the grip, the closed rule, the loop, the handoff, the communication is foundational. Why is this whole process the key, not just, say, knowing how to open and close the jaws?
Because literally every single detail we just talked about, managing cord tension with that U-shape, keeping the grip closed during movement, the smooth handoff, the active looping, the clear communication, all of it translates directly to using other more complex devices.
Like what?
Like passing a balloon for dilation, deploying a hemostatic clip, using a snare. All those procedures rely on the exact same core principles. Protecting the scope channel, managing friction so the device moves smoothly, and that synchronized teamwork between the assistant and the endoscopist.
So getting the biopsy forceps drill perfect builds the foundation for everything else.
Absolutely. If you can do the biopsy forceps sequence flawlessly, you've essentially built the muscle memory and the attention to detail needed to handle pretty much any flexible instrument that goes down that scope. It makes learning the next thing much, much easier.
That's a really powerful takeaway. Okay, so let's leave our listeners with a final thought. Since the main safety risk highlighted comes back to patient factors, specifically those blood disorders or thin blood, here's something to consider. How can you, during that pre-procedure prep time, when you're labeling jars, checking equipment, how can you proactively work to identify and flag those higher risk patients before the procedure even starts?
Yeah, that's interesting.
Is it a note on the chart, a visual cue in the room, a specific verbal handover point? How do you turn that awareness of risk into a concrete, proactive safety step for the whole team? Something to think about.